the end of the day, so you're not, you can go ahead and report.
Yeah.
I think that the main issue we need to worry about, and that's why I sent that email off, was to see whether or not they think it's prostate or bladder. At the end of the day, I don't think it really makes much of a difference. I think the right thing is going to be some sort of surgical removal of the bladder and the prostate. The only advantage if it is prostate, there might be a rationale for treating you with some sort of hormonal therapy instead, because if it's that aggressive prostate cancer, I mean, I hate to say this, we're not going to cure you.
Yeah.
You know what I mean? So do we want to put you through a big surgery when it's prostate cancer and we're not going to make you live a day longer? I mean, I hate to tell you that, but that's just a bad idea. My guess is that the data we get on this will be a little inconclusive, and because your PSA is quite low at 0.27. I think it's unlikely that it's prostate cancer. The kind of adenocarcinoma they're describing it, where it's called signet ring, it's not really the kind of cancer that is the kind of cancer you see in the prostate. Run-of-the-mill prostate cancer I'm talking about, the kind of stuff that you read about in the New York Times. And I don't think that it's any sort of colon cancer, because you underwent endoscopy and they didn't show anything, right? Then the question is, because we have to worry about that, that could be the case. I think the right thing to do is going to be to surgically remove everything. I think it should be done with a colorectal surgeon as well. And the reason for that is because I'm a little concerned that it's involving the rectum. So the reason why you want to involve a colorectal surgeon is because he's the one that's going to be best able to spare the rectum, right? Because he's better at that, finding the planes. And if they have to do something with the rectum in order to, because of that, okay, he's going to be the best one in order to put everything back together again, okay? Getting at the expertise of other surgeons is critical, I think, in terms of properly managing your care. I think I need, Dr. Belmont, needs to come up with a list. So let me ask you a question. Are you coming here because you want confirmation of what you're doing, or are you looking to shift your care?
Dr. Rittenhouse said get a second opinion.
Okay.
Dr. Rittenhouse was pretty clear when I listened to the report to get a second opinion. They have not seen this type of cancer.
Okay. So
I would
right.
feel more comfortable if you were here.
I actually think that, I see a lot of things, okay, where I think we might do incrementally better than they do out in the community, okay? But I'm not going to sit here and say, we're light years ahead of what they're doing, there are good surgeons everywhere, there really are. I think that for this kind of case, where you're going to need multiple different surgeons involved, you really benefit from having, and the medical oncologist and the integration of care, and you're really going to benefit from being at a place like this. Okay, but at the end of the day, it's up to you. And I did mean what I said, which is that there are good surgeons everywhere, and that anybody who says that they have a monopoly on good patient care, in my opinion, is lying. Okay.
I agree with that.
So the main thing is, I don't think we can have you wait around for ages to get this done. And part of my job is essentially to be a contractor. You know what I mean? And this is not a little thing that I can squeeze in. I know Dr. Bellman sent you to see me, but I think what I need to do is sort of get the ball rolling pretty fast, but then probably have one of my colleagues, who you'll meet. I'm not saying it's some mystery guy, but somebody who's able to get in the operating room sooner. I mean, right now we're booking cases for me in June, okay? And we can't wait till June. It should be done sooner than that.
Yeah.
So with your permission, what I would end up doing is emailing Dr. Belmont, Dr. Preston, who's one of my colleagues, and Dr. Goldberg, who's one of my colorectal colleagues, and saying, this is what I saw, this is what I think, can you guys run with this, and sort of handing it off to them. Okay? I think Dr. Belmont's got all the right studies. I feel pretty comfortable that this is localized. I think it's just the plan of attack is really important.
Yeah.
Okay? And does that make sense?
I don't think I could wait much longer if
Well,
I'm urinating more.
I would agree with you. I think this needs to be done. So I'm giving you my card, okay, just so you always, I don't want you to be out here saying, I don't know, that's not good. We need to make sure that things proceed. So right now, as soon as I'm done with you, I'm going to send an email to all these people saying, this is what I think, okay? And they should run with it, okay? But I want to make sure you have a way of getting in touch with somebody who's going to be responsible. And I'm going to talk to Dr. Belmont to say, does he need chemotherapy before the surgery? I think he's going to say no, but, I think they need to think about it. I think they need to say no, you know what I mean, as opposed to not saying anything. Does that make sense?
Yeah, Rittenhouse said no.
I think that's the case. Okay? Does that sound like a plan?
So here's my question. You're thinking it didn't begin in the prostate. You're saying it began in the
I think it
bladder?
probably began in the bladder.
That's what your sister said.
I'm just playing odds,
Yeah.
okay? We don't know, but those are the odds.
But have you seen this type of cancer before?
Adenocarcinoma? Yeah, it happens in about 5%. Bladder cancer is adenocarcinoma. So just to give you an idea, okay? The average, the busy surgeons that do remove a bladder, okay, do about 3 a year. Those are the busy guys,
Oh.
okay?
Wow.
The average urologist removes like 1 every 5 to 10 years, okay? The average busy hospital removes about 5 a year, okay? We removed close to 150 a year last time I counted.
Oh.
Out of the guys that do this surgery, the person who's the least busy is probably me, and I probably, in terms of cystectomies,
Right.
because I see patients like you where I don't want to wait around, and I probably do about 20 a year. So I'm doing one this week, one next week. The guy I'm sending you to probably does 3 or 4 a month. Okay, so I mean the idea is and we're better at it because we do more of it.
Right.
Okay, but again, Dr. Rittenhouse, I don't know how many he does, and he may be very good at it. I want to be clear about this. I just think this is complex, and I think it's not so much just the urologist, it's the urologist, the medical oncologist, the colorectal surgeon, the nurses, the anesthesiologist. Everybody's going to be a little more attuned with dealing with something like this. Okay?
So do you think it has gone to the rectum as well?
Well, I'm concerned the rectum's involved.
You
I mean,
are.
when I do that rectal exam, that is an abnormal rectal exam. Now, I do think that it's entirely likely that the rectum could be spared doing this, okay?
Okay.
And that you're not going to end up with a colostomy. But what I just said, I stand by. The person who's most likely to be able to spare it is the colorectal surgeon. The person who's best able to fix it, if there is an injury to it, is the colorectal surgeon. So we might as well have them involved from the get-go as opposed to wait. You know what I mean? Does that make sense?
Absolutely. So are you saying you don't think the bladder is involved?
I think the bladder's involved as well. I think
It
it's
is.
growing outside of the bladder, and the MRI even says this, it's right up against the rectum. Okay? Does that make sense?
Yes.
Okay. Okay, so I'm gonna give this to you, so you can get out of here, okay? I don't think you need any more testing. I'll try and get it so they can coordinate, so you come in, you see everybody, and you see the anesthesiologist at the same time, so you only, one-stop shopping, 'cause who wants to come back here over and over again? And I know you like us, but you don't like us that much.
So
Yeah.
he's looking at 7 to 10 days still in the hospital, and then 2 to 3 months recovery?
I guess more like, 6 weeks, 5 to 6 weeks. Yeah.
Yeah.
I mean, it depends on how you recover.
See, before all this, I was planning on moving to Pennsylvania, 600 miles away.
I'd get this taken care of first.
Actually, oh, yeah.
Follow-up is gonna be here, though.
Yeah, we'll be at the Brigham or the Farber.
So I'm going to wait for a phone call from somebody saying.
Yes, but if you don't hear from somebody, do not be shy. I have too many people that are shy. You know what I mean? That's not good.
When
You know
you're
what I mean?
thinking right away, are you thinking within the next week or two? If you
I-
have something available?
Within the next 2 weeks.
2 weeks.
Okay, but I don't know the other person's schedule.
Of
I just
course.
know that May is too far away. You know what I
Okay.
mean? And I think, and we want to getting 2 surgeons involved is always a little
Tricky.
trickier.
Mhm.
Okay.
So
Sounds
you
like
said Dr.
are you a nurse?
No, but I worked at the Baptist. for a while-
Okay.
long time. Dr.
Preston?
Preston works with you.
Yes.
and-
Dr. Goldhaber is the
I didn't
colorectal
get his last
surgeon.
name. Could you spell that, please?
Goldhaber, Goldhaber.
Okay.
So
Okay.
Dr. Preston is
I've already read about him.
he's more junior than me.
I heard.
But his focus is on bladder cancer.
Okay.
Very talented surgeon, has done a residency and a fellowship in cancer, okay? Has been on staff here for almost a year. He's very good at this. Dr. Goldhaber is, I don't know how long he's been on staff, but he's been around a lot longer than that. He's very good as well. I think between the two of them, they'll take, excellent care of him.
Well, you came very highly recommended, obviously,
Yeah.
and also Dr. Preston. I had not heard
Yeah.
Dr. Gold.
So Dr. Goldhaber is